Assalamu alaikum everyone. My name is Vania Shahid. I'm a fifth year MBBS student, and today I'll be going over ABG interpretation with you guys. So, I'll be discussing a case as we've already discussed the ABG basics. An obese 70-year-old man presents with severe acute abdominal pain. He has diabetes since 25 years, complicated by acute coronary artery disease, cerebrovascular disease, and peripheral vascular disease. So basically, these comorbids are hinting us towards the derangement that could be there. He now presents to the ER with sudden onset severe, poorly localized abdominal pain. To the surprise of the intern examining him, he has a relatively normal abdominal examination. Just lots and lots of pain. No vomiting, diarrhea, or any other GI symptom. ABGs are obtained in the ICU. The pH is 7.18, PCO2 is 20, HCO3 is 7, serum sodium is 135, serum bicarb is 7, and serum chloride is 98. Now, there's a lot of information in ABGs, and if we're not following a format, we might make a mistake or would get lost. So, we'll follow the 6-step approach. The first step is to look at the pH and to determine whether it's normal, acidic, or alkaline. The second step is to determine what is the primary disturbance, whether it is respiratory or metabolic in origin. Step 3 is only when the primary disturbance is respiratory in origin, and we have to find out whether it is acute or chronic. This we do via asking questions in the history. Step 4 is to calculate compensation and to see if it is sufficient or if there is a double disorder. For this, we use formulas that I've previously mentioned in my lecture, but I will also be sharing the formula that is appropriate for this case. Step 5, if and only if the disorder is metabolic acidosis, then we have to calculate the anion gap to see if it is increased or normal. Step 6 is only if there's an increased anion gap metabolic acidosis. In this, we need to see if there are any other derangements. So we calculate the corrected bicarb. Now let's look at the case again. The pH was 7.18. We know the normal value is 7.4 because we are taking the absolute values. So it is decreased and it is acidosis. Now the PCO2 was 20. Hence it was decreased as the normal value is 40. The HCO3 was 7, it is decreased again because the normal value is 24. So step 1 was to determine the pH, which is decreased, hence this is acidosis. Step 2 was to determine the primary disorder. Now we know that PCO2 and HCO3, both of them are decreased. But if PCO2 was decreased, then it should have caused alkalosis, and a decreased HCO3 causes acidosis, which is the case over here. Hence, the primary disorder is metabolic in origin. Hence, this is metabolic acidosis. As you may notice that words are getting added to the diagnosis, and that is the purpose of our steps. Step 3 was only if the primary disorder was respiratory in origin, which it is not, hence we're going to skip it. Step 4, we were supposed to calculate the compensation. So for metabolic acidosis, as I discussed in my last video, there is Winter's formula, which is PCO2 is equals to 1.5 into patient's bicarbonate level plus 8. So we input all the values and we get 18.5. Now the PCO2 should be near 19 and in our patient it is 20. Hence the compensation is sufficient and there is no added disorder as of yet. Thus we're going to call it compensated acute metabolic acidosis. Step 5 was only to be followed in cases of metabolic acidosis, and as that is the case, we're going to calculate the anion gap, the formula for which is sodium minus chloride plus bicarbonate. We're going to add all the values and we get 30 as the answer. Now we know that the normal anion gap is 12 and ours is 30, so this is increased. Hence, this is high anion gap compensated metabolic acidosis. Now, the last step was to see if there is any other derangement for which we calculate the corrected bicarbonate. The formula for which is measured bicarbonate plus anion gap minus 12. We add all the values and we get 25. Now we know the normal bicarbonate is 24 and this is a little above normal, so there is a little element of metabolic alkalosis. So our final diagnosis comes up to high anion gap compensated metabolic acidosis with metabolic alkalosis. So this actually simplifies how to interpret and solve an ABG. But there are other things that we can do with an ABG as well, is like to find the cause. For example, right now we know that it's high anion gap metabolic acidosis, and for that there's a mnemonic known as mud piles to find out the causes. So that can also be done, but for that you can refer to the book to find out specific causes for each derangement. We can also interpret respiratory disorders in this strip, type 1 and type 2. We can also use this strip to interpret electrolyte disturbances. And finally, we can practice other scenarios as well. I hope this was helpful. Thank you so much.